It was basically a session that was run on Sunday morning with Mohamed Moti and Jean-Luc Harousseau as our chairs. And what the faculty sought to do was to sort of map out, from a European and US perspective, the playing field for autologous transplant in sort of 2018. And my remit was to introduce some of the newer approaches to induction remission treatment, consolidation and maintenance that are currently under study. And I think the emphasis was that 3 drugs as an induction strategy are clearly now a standard of care. We do believe that one of the best triplets that's currently available is that of Lenalidomide, Bortezomib and Dexamethasone, which carries various acronyms, classically RVD, or depending on how the regimen is modified, VRD. And in fact, at this meeting, there's been a wonderful presentation by my colleague Dr. Richardson from the Spanish intergroup showing the efficacy of this regimen in their transplant paradigm with outstanding activity, but most importantly, very manageable toxicity, including low rates of neuropathy. And that's certainly what we feel has become a very important paradigm, is how do you use 3 drug platforms as induction strategies, minimize toxicity and maximize efficacy. And obviously we've had some very exciting data with carfilzomib, lenalidomide and dexamethasone, the so-called KRD regimen. And now, of course, the real sort of game changer are the advent of the antibodies. And current studies are looking at either RVD combined with daratumumab or KRD combined with daratumumab. And obviously we have some early data on the KRD daratumumab platform that are looking very promising. Similarly, we also have some information around elotuzumab combined with RVD. That's very promising as a platform, but it doesn't seem to have quite the same impact that daratumumab does when combined with the triplet. So we'll see how both of those strategies evolve. My focus in my presentation was also to look at really newer directions and talk really about the immunotherapeutics that are now sort of galvanizing our field. And that includes how we might think in a novel way about vaccination post-transplant. And my colleague Dr. David Avigan has done some revolutionary work, in my view, or very innovative work at least, looking at dendritic cell fusion vaccines post-transplant in a way to augment autologous immunity against tumor after transplantation. And then my other focus was to question exactly where will high-dose melphalan sit. Recognizing that it's an alkylating agent, it's been a wonderful workhorse over the last several decades, but it does have toxicities, both acute and long-term. And are there ways that we can think about actually not having to expose patients to high-dose alkylation in the future? And obviously with the revolutionary, truly revolutionary promise of CAR-T therapy, will we start to see other strategies of cellular therapy replace high-dose alkylation as an induction remission strategy going forward? So it was a very important session, I thought. I do want to mention that Dr. Harousseau did a superb presentation at the end of the session on actually the importance of cost. You know, how do we think about value in this setting? And I think that's something that's going to become increasingly imperative for us to address. Obviously, as we look at maintenance, now a standard of care, lenalidomide is clearly the backbone, and we add antibodies to that, and indeed proteasome inhibitors like Dexamethasone, for example. You know, how are we going to manage the cost of all of this over the long term? And I think one has to think in terms of value, and I thought that was a point that Jean-Luc presented beautifully, actually, was that the value of effective therapies that can be arguably, you know, prolonging survival and quality of life for years, whereas existing strategies don't have that ability, has to be recognized. And we have to think about then how we measure that on the one hand, and on the other hand, how we make sure that we can offer best therapies to our patients in every context that we possibly can.